is really limited. In a study done with Maureen Canavan and Helen Jack, we found about 60% of those with epilepsy and about 80% of those with schizophrenia who are hospitalized get the medications that they should be getting. That's a big gap. And for those with epilepsy, particularly, depending when and where, there's really a notable proportion of people who get maybe the right medicine, but then also many other things, and sometimes the wrong medication altogether. The economics, I think, is one of the most important things to talk about, because we've talked about how do you advocate? How do you put this in a language that people who are thinking about the whole of the country, its productivity, et cetera, might hear? And a study, again, done with Maureen Canavan and Dr. Ofori-Atta, we itemized, if we could put a dollar value on the lost employment, the underemployment, the overemployment, this was based on a large national cohort study in Ghana, the lost unemployment or employment is equivalent to about 7% of Ghanaian GNP. That is a huge amount of gross domestic product that is foregone. And this was particularly interesting to the Minister of Finance, Minister of Health, I think Prime Minister, the Budget Director, because when we invest regularly in malaria, and that's usually put about 3% of GDP foregone from malaria. So as others have said, I think this has been very critical. Family productivity obviously suffers as well, and this is largely unmeasured. So this is just among people who report and have mental illness, but the family, so it's probably 7% is an underestimate. And of course, the disruption and the difficulty in the community overall, particularly when mental health is dealt with in such a medicalized approach. However, despite that sort of background in Ghana, the current state, and really after a passage of a very modern mental health bill that is still in the early stages of implementation, there have been several initiatives that are emerging that I think are very interesting. And the first one sort of addresses the question somebody asked about religion. In Ghana, many, many people with mental illness seek care in prayer camps. And most of us have read about, in the US, have read about prayer camps right next to human rights abuses. They just go together. And these are usually places that reports are there is forced not eating or fasting, chaining, etc. Those are all the really difficult, hard places about prayer camps. But the public health side of prayer camps is they're community-based. People believe them. The community thinks this is something that actually could be used, something that's actually very hard to do when one is fully medicalizing mental health issues. Of course, and I want to report this study by Daniel Arias, who actually spent a summer visiting prayer camps and interviewing providers at prayer camps and doing the same thing at mental health hospitals and trying to figure out, is there any overlap here? Could these ever be partners and learn from each other? And what he found is there was a lot of desire each side to work with the other, but there were really serious challenges to get through. The biomedical model versus the spiritual model having very different views about the etiology of mental health, whether it's from a natural, medical, biologic, organic process, or whether it's from some extra, devil spiritual area. The question of appropriate treatment, what's really the appropriate treatment? Is fasting okay or not? Very large differences there. And most importantly was their different views of chronicity. That a biomedical model really believed you're going to take this medicine for a long time, maybe forever. And the spiritual models just, couldn't handle that, thought we must not have actually gotten rid of the spirit if you're still not able to stop the medicine and go back to normal. So there are huge problems to try to get these sectors to work together, without question. But there is one place where they are very much aligned, and that is they very much want to treat and return people who have these difficulties back to their communities and their families. We did find an enormous agreement between the two on medication. And this, I'll turn to the second study, which has been published in the British Journal of Psychiatry, a study of a randomized trial done in a prayer camp, which was really led by Dr. Ofori-Atta. This, in fact, was a randomized trial that randomized people to getting their usual care in the prayer camp or actually getting medical treatment, medications, psychiatric help, a weekly visit. And tremendous results from this, significant reductions in mental health symptoms in the arm that got the biomedical treatment. But the difficulty was, of course, the hypothesis was people would chain less if that happened. And though that did come down, there was not a significant difference in that. So this is still something I think really a place to work, really a place to understand and think, how could we take advantage, leverage what the community believes in these providers in prayer camps, but infuse it with some of the best from the biomedical side. I want to end to leave enough time for some comments or questions with what's next and strategic thinking. We have a big problem here. We have a big global problem, and it is hurting all of us. What could be done? So first, what about we leverage what already exists? There's an enormous movement in the globe now understanding the social determinants of health, understanding if we ignore the social determinants of health, we will overspend on medical care the way the United States has. What if we can leverage some of that movement? The movement towards measuring and understanding the power of social networks. Maybe even leveraging prayer camps. Certainly leveraging the community-based health models, such as what Fountain House is doing, for a bit more of a scale up towards that. I think we also know if we're going to plan strategically, we have to keep it simple. The best global health interventions are simple. You can tell anyone about them and the next person can take it up. So what are the easiest models? What are the easiest pathways, the easiest medication regimes? Third, I believe very strongly, and particularly in my current role as the president of Vassar, where we have 2,500 undergraduates, 18 to 22 years old, we have to address this among the youth. And I'm so inspired by what we heard today and how Fountain House works and others in this room work of including those with the lived experience right up in the beginning of designing the programs, giving the feedback, what's working, what isn't working. We know 20% of college-aged youth come to college with a DSM-IV diagnosis. They are in care. Then they get changed. They're suddenly out of care and in college. What are we doing about that? What are we doing about picking those students up, pre-matriculation, designing interventions with them that actually will change the way they live, and potentially in the most inclusive way, design something that when they go out, they can replicate as well? And then last, we have to change the dialogue. This conference and so many other efforts show that an orchestrated communications plan can really destigmatize mental health and, of course, enable the most powerful sources we have, which is the community. And I think if we can change the dialogue, continue to do that, this momentum will carry on. So I really want to thank you for your attention. We have about 5 minutes for any kind of comments or questions, so would anybody want to say anything or ask a question? Or there are a lot of people in the audience who will probably know the answer to your question.
I actually think you are the only one with the answer to this one.
Okay.
My name is Leon Zeitz from Cities Rise, and I would be really interested for what you think we can do to get university leadership, not just mental health departments or the psychiatric departments, to step up both globally but also locally to talk about mental health. Because at the end of the day, it's really inspiring what you're doing, and I think other university leadership should be engaged. So we'd love to hear your thoughts on that.
Yep. Well, that's a very good question, and it's not easy. It's sort of how do you get a group that actually doesn't think this is their job to say, oh yeah, this is your job. And I think the more that is worked around the edges to destigmatize around the edges, and the more that we understand the residents, you're living on this campus, this is your community, and that is where mental health is dealt with. It's not dealt with out of there, the better we're going to be. I think there are some levers. The truth is that students with mental health challenges do not graduate easily within 4 or 6 years, and universities are tagged a bit for that. That's like a quality measure in medical care. How many do you graduate within? So there are some levers that if we force the reporting of that, the public reporting of that, I think we'd be in a much better place for people to start to, it would be in their own agenda, regardless of the human rights piece, it would be in their own self-interest to say, we got to deal with this because these are the students that aren't getting the resources. And I plan to work on it. Yeah. That's all? Yes.
Actually talk to that issue
Terrific.
about students. So, storytelling is one of the most important things you have. And people with lived experience are the most important things you have in this dialogue, right? So what helped me go back to school, I was very afraid to go back to school because that's where I got sick, right? So what helped me was somebody coming into Fountain House working on her calculus homework, right? And seeing her as a person with the same illness as me doing it. There are some colleges who have mental health clubs run by people with lived experience who go into the community and they talk to the entire school. And let me tell you what happens every time I get up on the podium. I have people come to me and say, I'm struggling. You inspired me. I think I can do it, right? So we need that. We need to elevate the voices of people who are going through it. And the way to reduce stigma is also storytelling. You know, that we are human beings with very complex lives who can succeed in college with the right support. So we got to find those people and elevate their voices.
Could you remind me, was your name Betty? Yes. I thought so. Amazing, Betty. That is exactly what we need. The voices of the community really telling the story and the leadership of that community listening. So thank you so very much. I think that's a perfect place to end. Thank you.
Okay, before you all move, if I could give you some vital information. You are going to have a 10-minute break, so please return promptly to the parallel and breakout sessions. And I want to bring all of your attention to the end of the day. I'd like to tell you, we haven't quite saved the best for last, but at least one of my very dear friends and favorites, Dr. Vikram Patel. You need to be back in this room at 5. We will get you out by 5:15, and then we will move you to Fountain House en masse, in Uber, on the subway, anywhere you'd like to go. And we'd like to invite you to come and see our community and our social movement that has been in existence for more than 70 years. We are now serving more than 155,000 people daily around the world. It's not enough. There are many more waiting, and we need your help to spread the word. So thank you. 10 minutes for break. Go to your breakout when you hear the chime. Sorry, I apologize, I got ahead of myself. You need to be back in here for the next session, and we've heard a lot today about private-public partnerships, catalyzing investment. That will be our next session in the auditorium. You have 10 minutes.
You can cause feedback or any.
Okay, so
Just want to see the green light.
First, I'll
Okay.
show you.
That's it.
Okay.
One switch right before you start talking. Will to turn on.
So they never had it?
That's on.
That
Yeah.
night?
You want to turn
Well,
it
I
on once
never-
right before you start. That's it.
That would make it happen.
And there would be water up there too.
Great.
That's perfect.
Okay.
So I'll make this easy. This one, you're looking for the green and white checkered flag. This I just tucked under there, so you'll have to work to reach.
Okay, can we,
Nothing is happening on this
but
computer.
can we have that up so we can see the slides, so we're not looking at the
It
screen?
doesn't
Oh,
work
it
like
doesn't
that.
work like that.
Your slides are coming from the computer in the booth, and there's no way to, we would have, if that's necessary, we can load it on here.
Necessary,
But
right? They're
unfortunately,
gonna
I'm
come up
sorry.
behind us, that's not a problem.
Yeah, so
Okay.
it's more convenient to see. in
And
here.
on here, it's literally just forward, back.
Yes.
That's it.
And we'll, when you're up, we'll switch to your presentation and you'll be on the first slide.
Perfect. So maybe we could just stand here next to each other?
Yeah.
And just take turns talking.
Perfect.
Okay.
You ready?
Great, thank you.
Ladies and gentlemen, if you could please take your seats so that we can stay running on time. This is a very exciting panel that we have for you this afternoon. We're going to begin this afternoon's panel with a very special presentation. Thank you. If you could take your seats, please. Thank you.
Hello, good afternoon. My name is Jackie Elias. I'm a managing director at JP Morgan Private Bank. My job there is not banking, believe it or not. It's actually, I'm a philanthropy advisor, and I work with families all over the world on different elements of their giving. And so I have the great privilege of working with people who are just getting started in terms of, setting a mission, but also thinking about how they as family members will make decisions. And so I'm delighted today to be here as part of this amazing conference and to really be supportive of the work that the Fountain House has done, not only today in this conference, but also generally. So my role today is to be a moderator, facilitator for this next panel, which is titled Catalyzing Investment, Public-Private Partnership for Healthier and Longer Lives for Individuals with Serious Mental Illness. So the first 10 minutes of our session will be a conversation, or a presentation rather, by Virginia Smith-Swintosky from J&J, and Juste Kayihura from the Rwandan Commission of Health. And after their presentation, which will be about 10 minutes, we will then come back up here with another group of people who will join us for a broader conversation, and then hopefully we can also have a dialogue with you. So with that, please, I welcome Virginia and Juste. Thank you.
Okay, great. Thank you, Jackie. Thank you, and good afternoon. We are really grateful for the opportunity that the organizers have given us to share our story about the partnership that's happening between Johnson & Johnson Global Public Health and the Rwandan Ministry of Health. So it's nice to have our partners here together so we can tell our story together and take your questions. Just very briefly, at Johnson & Johnson, we are building on our company's 130-year legacy of blending heart, science, and ingenuity to tackle some of today's most pressing public health challenges and deliver on the promise of improved health for all, everywhere. And I don't know if you know, but Johnson & Johnson actually has a very long and strong legacy and history in supporting research and development of innovative therapies for persons with serious mental illness of more than 60 years. And we remain committed to that space, and actually there's fewer and fewer companies that are actually focused on this type of research. We're also working on integrated solutions beyond the pill to ensure that patients have the best possible healthcare outcomes. So I'm a member of our Global Public Health Organization at Johnson & Johnson. We've been focused on infectious disease for more than 25 years as part of our public health work. And I'm very proud to say that just 2 years ago, we actually started a mental health program, and I lead that program. In global public health, we believe that all people, no matter where they live, deserve timely access to life-saving innovation. These medications need to be available, they need to be affordable and accessible. I'm just going to go over some of the stats. I think we all know that globally, 1 in 4 of us will actually experience some type of mental disorder in our lifetime. But mental illness, as has already been mentioned, actually disproportionately affects persons living in low and middle income countries. And one of our mandates within global public health at Johnson & Johnson is focused on those countries. So, as you know, 3/4 of persons suffering from mental illness live in low and middle income countries, and fewer than 1 in 50 of those persons actually have access to some type of mental health care, not even quality care, but access to some type of mental health care. And importantly, In many countries, there's no budget item in the healthcare budget for mental health, but in some where there is, it's usually less than 1%. This tells a little story about why we chose to work on mental health in global public health. So in 2016, members of our leadership team within the public health group actually visited Rwanda. And we had a very personal interaction with a young man and his mother who told us their story about his struggles with some of his healthcare issues. During the day, his mother used to have to chain him to a tree just so she could go out into the field to work, to provide for her family. And then when she came home, he was unchained and brought into the home. The reason for the chaining wasn't any type of punishment. It was honestly just to keep him safe, but also to keep their neighbors safe, because the neighbors were quite concerned with someone who had kind of abnormal behavior. She and her son didn't understand what was going on with his health, and they didn't even know it was a mental health issue at the time. But a local NGO that was focused on healthcare were doing door-to-door visits and identified this young man as having schizophrenia. That changed their life because they connected the young man and his mother to care. He was able to get access to oral antipsychotics and be able to stabilize his symptoms. However, he continued to struggle with relapses and also with some of the side effects of that medication. For our leadership team, while we were there, we saw an incredible opportunity to actually bring some of the innovative products that we have, longer-acting antipsychotics that don't have to worry about stockouts, don't have to worry about traveling hours to get to your doctor every month to fill a prescription, and knowing that a patient could then continue to be on their care could really change the lives of persons like this young man, and also potentially lead to better health outcomes and productivity for that young man and his community. So I'll turn it over to my colleague for the next slide.
Sure. Thank you, Virginia, and good afternoon, everyone. I'm Just Kayura with the Permanent Mission of Rwanda to the United Nations. So in Rwanda, we have done tremendous work in terms of mental health. This just shows you the before 1994, and most of you know that this 1994 is very dear to Rwanda. Before, that was when the genocide happened, genocide against the Tutsis. So before 1994, there was only one psychiatric hospital, no local training programs in psychology and psychiatry, no mental health policy, and a widespread human rights abuse and misunderstanding when it comes to mental illness leading to stigma. In 1994, as you might know, the genocide against the Tutsi took over 1 million lives. And during that time, over 250,000 women were raped, and this perpetrated HIV and AIDS, and it was used as one of the weapons of war, as you can imagine. So the human resources and infrastructure at health facilities, along with many other services, were wiped out. This was such a tremendous challenge for the survivors with physical and emotional wounds, but no way to get any type of help. Now, the genocide has had a huge impact on mental health in Rwanda. There's an increased burden of mental health disorders, PTSD, depression, anxiety. The prevalence of PTSD in 2009 was about 26%, which is one of the highest. And as you can imagine, 66% of those affected were women because of what had happened about 15 years before. People suffering from PTSD also suffer from many other issues such as depression, drug abuse, and headache. Now, after '94, now Fast forward from 1995 to present time, we've set national mental health policy. There's a creation of a fully staffed mental health department at the Ministry of Health. And I'm not gonna go through all of those, but you see that the country has done tremendous work when it comes to mental health. Now, why are partnerships important? Partnerships really it support working towards the same goal. It can achieve greater outcomes than individuals or organizations acting alone. There's no single organization or individual that can tackle mental health issues and succeed by themselves. So partnerships strengthen the capacity of projects and services to broaden their reach and engages more stakeholders and achieve shared objectives. And at the end, it's a win-win situation. All the partners win if it is a success. And what makes our partnership work? We have clear priority, health priorities, which is under the second pillar of the National Strategy for Transformation. This is a 7-year plan for the Rwandan government, and a healthy population is one of the pillar. We have clear areas for collaboration and leveraging for partners with defined outcome. And finally, there's a sustainability plan, which is considered from the beginning. Having a clear plan and setting up a clear monitoring and evaluation system, it supports or help coming up with a sustainability plan. And I think, yeah, that's it for me. Thank you.
Thank you, Just. So we were very impressed by what we were learning was happening in Rwanda. And we had actually, when we started our program, we were visiting countries in Sub-Saharan Africa, South Africa. We were also visiting in Latin America and Southeast Asia, really to try to understand how mental health care was being delivered, what were the best practices, because we didn't want to reinvent the wheel at all. We wanted to get behind those things that were working well and try to help scale them up and bring them to the next level. In May of last year, we sat down with the Ministry of Health and we talked about what are your top priorities, what's most important to you, and we talked quite frankly, well, this is who we are, this is what we do well, these are the things we actually don't do well. Does this even resonate with you? Is this something that we could potentially work together to build upon the incredible work that was already happening in Rwanda to then continue to improve mental health care? And out of that discussion, we actually came up with a plan for a three-pronged approach. The reason for this three-pronged approach was wonderful that it aligned with the priorities of Rwanda, but interestingly, they resonated with every country that we had actually visited as well. So first was determine the prevalence and burden of disease. Many of these countries don't have much budget to put towards actually conducting epidemiological studies to truly understand the burden of the problem. So then it has the impact of affecting policy. It has the impact of resourcing and budgeting because they just don't know how services are being utilized or how big of an issue it is. So to that end, we've actually partnered with the government to conduct a nationwide survey of about 8,000 households. It's a broad survey of mental illness, and for the first time, I believe, in the country, we'll have a comprehensive view together of what the burden of disease is, the utilization of services to really inform those policies and resources. Secondly is increased access to mental health care in communities. As many people have said, it's very important that people actually have access to care where they live. Often in low and middle income countries, mental health care is actually quite far away and usually in the urban centers or the capital cities, and that can be a tremendous barrier. So we've actually partnered with an NGO, Partners in Health, who has already been in Rwanda and working for about 7 years now, where they've developed a mental health care program in communities with really impressive outcomes, both for patients, caregivers, and for healthcare professionals. So we're trying to work with them to scale up that program in 2 additional districts that the government has already said, if you can replicate that in a cost-efficient manner, which we're working on, that would be something they would scale up nationwide. So that goes to the sustainability piece of, well, what next will happen? And the last thing is enabling access to essential and innovative medicines. So I mentioned, we thought our long-acting injectable would be a great product to bring forward, but we quickly learned that many of the medicines that are on the essential medicine list were not even being accessed. And part of that was affordability, part of that was actually just availability of those medications. And so we've been working with the government. We actually participated in a competitive tendering process for risperidone. We are conducting clinical research. I think this is important because it's not actually about efficacy and safety of an investigational drug. This is actually a product that's been on the market, the long-acting injectable. What we're trying to do together with the government is understand what's the health, economic data, and social impact of that particular product in Rwanda. Is this actually bringing any value at all over the oral medications that are available on the essential medicine list? And so we're in the process of doing that. We're also building capacity to conduct clinical research. It's never been done actually in the mental health field in the country. And also learning many scales and conducting research. And lastly is providing medical education. So in conclusion, what we're trying to do is create a model of quality care that would be affordable and scalable to other countries. And Rwanda is really kind of blazing the trail here as the proof of concept. So hopefully the next time we have the Healthy Longer Lives Conference, we can give you a report card of how well we've done, because we're just at the beginning of this partnership. So thank you very much for your time.
I'll sit here. Yeah, I can do that. Sort of in the middle. Thank you, Virginia and Juice. That was really interesting, and I think it just sets up a really nice way for us to start our conversation. And I would say that one of the things that's interesting about this conference is that when we think about mental health, mental illness, it truly is an international crisis in some places, as you mentioned in Rwanda, but also it's something that obviously many of us have worked on in different ways, but to be able to actually have a conversation and bring all those themes together is really, quite a pleasure to do. So as I mentioned before, my name is Jackie Elias, and I'm with JP Morgan, and today we have with us some very impressive people on the dais with me, but also people who are very passionate about mental health, mental illness, and improving the lives of people who are dealing with serious mental illness in particular. So we have about an hour in terms of talking, or actually 55 minutes. And so I will introduce the rest of our panelists, but also provide a way for us to just answer 3 basic questions and with goals in mind. And then hopefully we could also just have, all of our panelists ask questions of one another. So hopefully this will be very interactive. So to my right, and I have to find everybody's name because I don't have everybody's name. There it is. Oh, there it is. Okay, there we go. So to my right, we have Andrew Adams. He's the co-founder and general partner at Oak HCFT. And I want to thank Andrew especially because he didn't know he was going to be on this panel until yesterday. And it was actually a wonderful thing because the person who was supposed to be here, his partner in business, is now the First Lady of the state of Connecticut. And so she is celebrating something really exciting. To my immediate right is Giovanni Colella. He's the CEO and co-founder of OODA Health. And he's actually coming to us from Italy. I know you live here in the States, but you just came in. Yes, so we're happy to have you. To my immediate left, I have John Boyd, who's the CEO for Mental Health Services at Sutter Health, and he's the chair of California's Mental Health Services Oversight and Accountability Commission. That is a mouthful, and I know it sounds like a really big job. And to my further left, we have Jerre Stead, who's the CEO of Churchill Capital Corporation, which I must say, when I spoke to him and I read his bio, it is really long because this man has done so many things in his life, and it's impressive. And I really appreciate the fact that you're here with us because I know you're a very busy person. And of course, we've met Virginia and Juste, so welcome everyone, and I'm really delighted to have you all here. So as I mentioned before, if we can maybe focus in on some of the things that Virginia and Juste talked about, which is really about the motivations. Why are people coming together to partner? What are the circumstances that bring people together? And two, we're going to provide examples because that's really the best way, hopefully, of sharing best practice. And then three is really around lessons learned. I find that I've worked with some very successful people in my life, and one person said to me in particular, if you cannot cringe at something you did 5 years ago, there's very little possibility that you've learned anything. And so I'm sure, so at this point, I would hope that we can have one of these cringing moments when you're telling your stories. So I'd like to open up the question with a kind of a softball, but in some ways I'd love to hear from everyone here about, perhaps give us a reason as to why you're doing what you're doing in terms of looking at both, whether it's private sector partnerships or public sector, and perhaps bring it to life in terms of your own path to this kind of work. So I'll pick on John since it's right here.
Why not? So, I do wear a variety of roles, and so I'm going to answer this from a few different perspectives. First and foremost, I'm passionate about this, and I do what I do because we know that we're talking about an issue that absolutely affects everybody. It's one of the few topics that in every room you're in, you can raise this issue and know on some level you're speaking to someone's need, experience, or perhaps where they face a barrier. We live in a time where public and private sector partnerships are absolutely the only way that we can bend this curve. The capacity and desire related to the social movement and naturally changing the narrative around mental health and suicide prevention, I think we've heard a lot of that today. And it's our responsibility to now shape that more broadly and amplify that in the spirit of hope to populations of people. Wearing my health sector hat, outside of the frank reality that we've got so much work to be done to integrate physical health and mental health, there's the truth that every single day on average in this country, we lose one physician to suicide per day. That has a profound spiritual, community, actual financial impact to us. So from multiple lenses, this blend of partnerships, I think it is the only way that we can sustain ourselves as a community, both culturally, economically, and spiritually, frankly.
Yeah. And Jerre, one thing we talked about during the prep was that, you see mental health, doing work not only from the business side, but also on your philanthropy as the place where you can have the most impact. And I'm curious about what, again, to the idea of the partnerships, but why mental health partnerships in particular are really important.
Yeah, no, happy to. Mary Joy and I got married when we were 19, had no money. And we said someday if we could ever make a difference, we would like to bend the curve of health in general. And mental health, Alzheimer's, and obesity are the three, as most of you probably know, largest cost of our world today. And this particular program, I'm so glad we got it, because if you think about what we're calling it, each of those three have an incredibly negative impact on shortening lives. So in this case, we started serious investment and then matched it. We don't contribute money. We don't give money. We invest money for nonprofit purposes. And we're very proud of what we've done. It's a wonderful honor to be here, and thank Fountain House and everybody else, and certainly Johnson & Johnson for the work they're doing here. But it's so important to recognize that, I'll just quickly give you the example of what we've done with Alzheimer's, that we need to do and can do together here from a mental health standpoint. My mom had Alzheimer's for 15 years. I got to meet, whether I wanted to or not, hundreds of people who had the same thing. And I said we had to change that. So 13 years ago, we started the Alzheimer's Research Institute in Phoenix, Arizona. Today, we're doing an $850 million study for prevention of Alzheimer's. And the probability, it may not excite you all a lot, but it's a 31% probability of success. That's actually magnificent numbers if it works.
That's excellent.
So our whole goal, as I was saying to you, is to bend all three of those curves. The mental health one is it can have such an incredible impact. You all know this, but the ability, because you're right, if you sit down with any group, any place, you're going to hear either Alzheimer's, mental health, or both.
Yep.
And so the ability to make that curve change, and just a quick comment on Alzheimer's, the way we did that was through charity giving, government giving, and in this case, pharmaceutical giving. And that's what we're set out to do, and can do and will do with mental health too. And what you said was so true.
So Andrew, we're talking about success rates, and I'm curious about, you as a venture capitalist. I mean, obviously, this is a business for you, but nevertheless, it's not just the dollars and cents that are motivating what you're doing. So can you talk about
absolutely. So we are a for-profit investor, but we have been longtime investors in the healthcare industry in general. And our strategy is really driven by a deep mission around delivering high-quality patient care and a great patient experience at scale. And the only way for us to do that is to have very strong partnerships with nonprofit organizations. When I look at where we allocate our capital and where we spend our time, mental health is at the top of the list, and it has been for almost 20 years, beginning with an investment in a substantial inpatient facilities operator. We've recently come back into that category, and really because we want to be part of the solution to providing access on the front lines to that care that's needed in the appropriate setting. And many of the partnerships that our companies have with nonprofits are specifically with health systems, where they're not properly equipped either through the ER or through the personnel or through the specialty to be able to treat the populations that are coming through the doors every day and in desperate need of help. And that's where companies that we partner with come into play. That's all they do. That's all they think about. They've been doing it for decades, and they have that specialized experience and the tools necessary to deliver, again, high quality care at scale. And we're pleased to be cutting the ribbon on a joint venture with a hospital system in Joliet, outside of Chicago. Heavy Medicaid population, a dearth of beds and access, and I think that's a great example of how we're trying to be part of the solution and doing that on a national scale.
That's really interesting. And now I want to make sure, Giovanni, you share with us also why. I know you have also a professional interest in mental health, being a psychiatrist, correct? A recovering psychiatrist. That's what my husband always says about the law.
25 years.
Yeah.
So yes.
Well, you still remember some of it. So, but at the same time, again, you also take a very holistic approach to not only how you now are as an entrepreneur, but also bringing what you learned during your clinical years.
Yeah.
May you talk a little bit about that?
Well, thank you. Yeah. So I'll bring the other side of the venture capital. Actually, both sides, because they're investors with us. So we're working with them quite a bit. So, from a very practical standpoint, the first thing I look at is where's a big opportunity? Just practically, and I can't think of anything bigger. I mean, huge worldwide problem, lack of supply, huge demand. It's an opportunity right there. Second thing, I think, okay, well, who can teach me? I mean, at the end of the day, an entrepreneur is just somebody struggling, trying to make a living that can't find a job. I need somebody who really understands how to do it. And that is in the nonprofit sector. So that's where I bring together, if I had to start a bit, and I thought about it a lot. The reason I didn't do it in the behavioral health space is more personal than business-wise. I would go right away to talk to Fountain House, clubhouses like that, where they really, really understand how to manage behavioral health from a cost-efficient way. And then I would bring in entrepreneurial expertise, and I would match the two in what I believe can be a huge opportunity from both a capital and wealth creation perspective and a social impact. So I just think I actually am very optimistic. I'm optimistic about many things in life, but of this one quite a bit because it's there, it's happening. I mean, I see venture capitalists talking about this all the time. And so the opportunity is there. Now we really need to think of it, and we need more entrepreneurs. Again, I'm a little biased on that, but more entrepreneurs to come in and start kicking the tires and say, I want to do it.
I'm curious about,